We've explored the groundbreaking journey through the history of breast cancer surgery in our 3 previous videos. In this bonus chapter, we will look at specific details of the landmark studies, the Milan 1 and NSABP B06 trials that are not often emphasized, but provided real clues about survival and recurrence that would be revealed by the studies which were to come. Once there is data to define survival difference between 2 modes of treatment, we can retrospectively examine the data that was historically reported and how it provided clues to what was to come. Looking back, there were already suggestions from the Milan 1 and B06 trials that the conclusions from Dr. Martin's study could have been predicted. As for all our educational videos, there will be references provided along the way for you to verify the facts presented. Please note once again that this information is not intended as a substitute for a surgical consultation, and patients are encouraged to see their doctor for appropriate treatment planning. There were multiple reports published from the Milan 1 and NSABP B06 studies, but these are the 4 that we will focus on for this video. Here we see an excerpt from the published report in 1985 for the Milan 1 trial. As discussed previously, the treatment outcomes for women who underwent quadrantectomy and mastectomy were analysed. These are survival curves of the study cohort presented in the 1985 report of the Milan 1 trial. The y-axis of the chart represents the proportion of women still alive, and the x-axis represents the time elapsed from the point of surgery. In this case, the dotted lines represent the survival curve from women who underwent a Halsted mastectomy, while the solid line represents the curve for women who underwent quadrantectomy, followed by radiation. The chart on the left compares disease-free survival, in other words, the proportion of women alive without any evidence of disease. The chart on the right represents overall survival, or the proportion of women still alive, regardless of whether she has detectable disease. We can see that the 2 curves separated about 10 years after treatment, with a higher proportion of women who underwent quadrantectomy still alive. Through the persevering work of pioneering surgeons like Professor Veronesi, we have 20-year survival data from the Milan 1 trial. This was reported in 2002. Here are the survival curves of the Milan 1 trial after 20 years of follow-up. The thicker lines represent the survival curve of women who underwent mastectomy, and the thinner lines those who underwent quadrantectomy. The chart on the left compared all women in the study cohort divided in their respective groups. This showed no difference in survival. However, what was interesting was that when they were separated according to their tumour sizes, for those who had cancers larger than 1 centimetre quadrantectomy with radiotherapy, appeared to confer a survival advantage with a greater proportion of women alive 20 years after treatment. This bears repetition for emphasis. The reported 20-year data from the Milan 1 trial suggested that women with cancers larger than 1 centimetre in size had higher survival if they underwent breast conservation treatment than if they had a mastectomy. In 1985, Professor Bernard Fischer reported that women who underwent segmental mastectomy had survival that was no worse than those who had total breast removal. What is of interest but seldom emphasized is that the data showed that women who underwent segmental mastectomy and radiation had better disease-free survival than those who had a total mastectomy. The 20-year follow-up data for the NSABP B06 study was also published in 2002. We will recall that Professor Fischer reported in 1985 that the study analysis suggested that patients who underwent lumpectomy and radiation had better survival than those who had total mastectomy. In this table, it is presented that after 20 years of follow-up, women with lumpectomy and irradiation had a local recurrence rate of 2.7%, and those with mastectomy had a local recurrence rate of 10.2%. As the term indicates, local recurrence is the return of cancer within the treated breast or in the skin over the chest after a mastectomy. In summary, after long-term follow-up of patients in the NSABP B06 study, the data suggests that local control with breast conservation treatment may be better with fewer recurrences observed than after mastectomy. Having journeyed through the history of the surgical therapy of breast cancer, we can appreciate that the basis for breast conservation treatment is grounded in rigorous science recorded in medical literature. The data analyses of the Milan 1 and NSABP BO6 trials, which we have discussed at some length in this bonus video, had elements which pointed to the possibility of better survival with breast conservation, as seen in the 2007 Western Australian study. It is hoped that this will assure women with early breast cancer that breast conservation treatment is a good surgical option and may be superior to mastectomy in terms of survival and local control. In the next video series, we will discuss the secrets of modern breast cancer surgery. We hope you will join us to discover them.